move their eyeballs a lot. Essentially, your skin creates a new, your eyeball creates a new skin every 24 hours, so it does heal itself, but it is uncomfortable for the patient, and they will really focus on it. When does it happen? It happens usually in recovery room, when the patient can't protect themselves, they're still groggy, and people are putting cold gauze in their eyes, and they inadvertently scratch the eye. For you, when you're doing ice to the eyes, you want to put it from the top down. You don't want to put it directly on like this. If you're putting it from the top down, it's sitting in this area, and if anything, it's pushing the eyelids down. When people have had eyelid surgery, you may have seen, they may not be able to fully close their eyes. The ointment will be ordered for night as well, and that ointment goes right on the globe, not on the eyelid incisions typically. It goes right on the globe to protect it from drying out. But the ice is, again, very important with that. Expect that there's going to be some bruising, but if patients complain of severe pain, severe swelling in the neck area, these are the surgical emergencies I referred to. Pain beyond Percocet for the eyes or for the facelift patient is very significant because that pressure is causing so much pain. You can give them morphine, it's still not going to take it away. And the pain in the eye is usually because it bleeds and creates pressure on the optic nerve, and that can cause blindness. 1 in a million cases will cause blindness. I haven't heard of any in this area, but still, it's something you would always worry about. And that's where not only calling the attending, but getting the house officer up or the surgical PA down up from the floor. And those are the main things about the facial area that are going to be a little different. For breast procedures, I like to keep the patient elevated a little bit, especially if they have a flap, because if they're lying flat, the flap's going to get congested, it's not going to drain as well, and if there's a venous congestion, then it's going to eventually block the arterial inflow because the pressure's too big. So essentially elevate them a little bit. With breast, it's a simple test that my partner likes to use. You're going to call them up and say, I'm just not certain that this breast feels firmer than the other one, and they both were, let's say, a breast reduction. So the simplest thing is when you open your hand, the breast should feel like your thenar region, which is soft. If you make a fist and it's hard, and the breast feels like that, that's a reciprocal. And that applies to the flaps as well as a breast reduction. Augmentations are going to feel firm, but still, these are things to go by. You may only see, on a breast case, the skin outside the dressing. You're not going to see the flap and things unless they told you to do flap checks. Vanium is very important both for the abdominoplasty patients as well as the breast patients because things are done with the muscles. The muscles have been manipulated. So offer the Vanium. We have it only as a PRN because we don't want to give them round-the-clock Vanium, but typically my patients will get Vanium every 4 to 6 hours. So offer it to the patient. I think it's an important thing. There's a difference between pain, which is sharp, and pressure, which is relieved by the Vanium. Patients may not know initially because this is a new procedure for them. Just say, let's try the Percocet or the dilaudid BCA. If that doesn't work after an hour, I'm going to come back, offer them Valium, and all of a sudden you're going to find they're going to get it a bit easier. Reinforced dressings we call. Drainage output, if it really is excess, you're emptying the bowl twice in a shift, bloody, call somebody. Because let them know, that something is going on just so they can be aware that they may be coming in again.
How much is excess for the drains? Because, a lot of the abdominal ones.
A lot of the abdominal ones, that first night, they're going to empty 60, 80 a shift. But if you find you emptied it and you go back 2 hours later and it's full again, that's a reason to call somebody. Full with blood, not watery.
If it's watery, it's okay.
If it's watery, it's typically okay, yes. But again, if you're concerned, call. But if it's watery and try to, it looks like a wine punch first night, that's okay. But if it's frank blood, then, that's a whole other story. And it's filling up almost as fast as you empty it. Abdominoplasty patients, the main thing is positioning. You want to keep them flexed at the waist. I tell them to think that they're sitting in a beach chair, lounging. So pillows behind the knees, pillows behind the back, or the bed in that beach chair position. When they get out, especially if they've had breast surgery or arm surgery, you don't want to pull on the arms, you want to gently push on the back, and you want to keep them bent. You want to keep them dangling their feet for about 5 minutes before you stand them up. Often these patients, any of these patients, will have had, they'll feel vasovagal if they get up from lying down to a standing position. So you have to stage it. What? 5 minutes after the warm time. So the main thing is you want to be able to keep them flexed at the waist. Valium is very important. Reinforcing dressings, as we said earlier. And if there's excess pain or drainage output, as I just mentioned, you want to call somebody. Last couple of things, body lift patients are different. The scar goes all the way around. You can't flex them too much because it pulls on the lower back. Those patients are typically a little bit bent at the waist in the bed, but typically they also may be flat. Different thing for them is when you get them out of bed, you're not sitting them at the edge of the bed, you're going from a lying to a standing up, making sure you're supporting them. Urinating in the shower is not an unusual thing, especially for women. It's a little harder for them to do it, but it's easier for them sitting on a toilet just to urinate. There are female urinals, I've learned, because patients have used them. They have a lip to catch it. I tell them to buy that ahead of time. I tell them at home to have an extended toilet. But if we can have that elevated toilet seat here, it's a little bit easier, so they don't have to go down as low to go to the bathroom. They're going down half as much. And it's an uncomfortable procedure, so expect that. But again, if things are excess, you want to give them a call, the attending. For breast procedures, just really quickly, we're not going to go into other reconstructive procedures. Things to think about is if somebody's had a lymph node dissection, you want to not use that arm at all. There may not be a sign on the bed. If you see in the orders that they had a lymph node dissection, put that sign above their bed, because that's a very important thing for no IVs, blood draws, or blood pressures in that arm. Head to bed elevated, as we said earlier, just a little bit to keep the tissues from swelling. Expect the pressure, and again, back to that Valium. Expander, all you're going to see is the dressing up here. Don't take down the dressing. You may want to have dressings at the bedside for all these procedures for the surgeons. When they come in the morning, you just ask them if they want those. All you're going to see is the skin, if it looks normal color or not. And again, excess drain output, things are filling up, they don't look watery. Other procedures involve flap checks. Flap checks, again, is that softness that we talked about earlier. They may ask you to look at the color. Pale is good. A light colored flap is a healthy flap. You press on it, it looks pale, but you see some capillary refill. Something that's purple and dark is not good, and that's the reason to get it in. Something that immediately refills after you press it on it for capillary refill. If it's too rapid, that's not a good sign. That means it's getting venous congestion. Lymph node dissection we already covered. The last thing is there are no stupid questions. So if you have anything, please call. You're not bothering us. And if that attending says that they're being bothered, contact a higher up in your department. Contact Dr. Price, or whoever the chief is of plastic surgery, because it's the day of the belligerent surgeon is really gone for the most part. I hope you all can agree. Maybe not, but call them, or just again when the time is right, ask somebody else. How do we approach this doctor? What's the best way? Or just bump it upstairs. And I think that's the most, the advice I'll give you with that. I prefer to be called over the house office. And the house office has no clue about the patient, will often come up, run EKGs, chest x-rays for a temperature of 101 after a patient had 8 hours of surgery. There's no reason for that. That's coming from atelectasis. So preferably for my patients, and I'll speak for my partners as well, don't call the attendant. Don't call the house officer. Call the attending directly, because we may just say, give them some Tylenol, get them out of bed, get them in central responder. Okay, I'm sorry we have limited time for all you, but I will stay and answer questions. But thank you.
Thank you very much. It was very informative.
And we'll leave the talk here. So
Liposuction, do they have any limitations on moving their arms?
you want to keep, if it's just strict liposuctioning versus a brachioplasty. A brachioplasty is arm surgery where you take out the skin.
Mm-hmm.
So typically you don't want to be pulling them by their arms. You want to support them in the back when you're getting them up, and just arm elevation. But no, they can do things. Because liposuction is just removing the extra fat. They're going to swell, but keeping the hands elevated, higher than the elbow.
That body bra, does the arm sleeves and then the bra?
Typically, a lot of us don't use the arm initially because it's hard to get on and off, but yes, if they're on, you just leave it on. If it leaks, just take it and push a pad right under the, in front of the breast, under the armpit, on the axilla.
Use a lot of ABDs.
Yes, and we tell patients at home if they don't have them, use maxi pads, they're very absorbent.
With lymph node dissection and mastectomy, I know we're not allowed to do blood pressure or IV sticks on that freshly operated site.
Yes.
We can do that. So when can you actually draw blood or do blood pressure,
Do
like
that.
later on the
Yeah, actually,
coming years?
you're going to see a lot of sentinel lymph node biopsies, which is a sampling of lymph nodes. That's not an axillary dissection. That really doesn't disrupt the flow of the lymphatics. So those patients, later on, if they're sure they had one, they can get blood draws and IVs. But typically, if somebody's had a full lymph node dissection, that's for life. Because a simple IV, a simple blood pressure can cause lymphedema that may have been dormant for years. Now the question comes in, if patients have had bilaterals, then that's something that you're going to have to pick and choose. But now that we're seeing more sentinel lymph node biopsies, lymphedema is becoming less. Good question. Anything else? Thank you. I'm sorry.
Thank you very much.
Okay, a little late.
Wonderful, yeah.